Dzień dobry, witamy Państwa
Good
na
afternoon, ladies and gentlemen. It's our 21st meeting today dedicated to working with trauma and on how to best prepare to help people who have experienced trauma and very difficult situations related to the war. Today, it's our great honor to host Professor Patricia Resick from the United States, who is a clinician and she studies therapies and is a creator of a program addressed to people with the most traumatic experience. So today we're going to immerse into cognitive processing therapy for trauma. The professor has created a whole program, which is an incredible method. She focuses on what is most important, and just within a few sessions, she's able to really help people who have experienced, who suffer from such a severe condition as PTSD. I'm going to give the floor to Patricia in a moment, who's going to talk about this approach, but I would like to, first of all, thank her for her openness, her readiness to share the materials, to encourage people to get prepared for this work, to get proper preparation, to go deeper into empirically tested methods. Patty Resick is very well known for her social approach to the profession of a clinician, psychologist, psychotherapist, CPT psychotherapist. And we really benefit from that. So it's a great honor for us to have you here. And the floor is yours. Thank you.
Thank you. Let me pull up my slides. Okay, I'm giving you an overview today of cognitive processing therapy. This is not a full training, but I will show you resources. And someday I hope we'll be able to do a full 2 or 3 day workshop, maybe even in person, you never know. These are some resources. Our website for CPT is cptforptsd.com. You can access the English manual there, not the Polish one. It has been translated to Polish. We are just about to have a Ukrainian version. It's been translated, but they're working on final proofreading. And so I'm going to send it to Iga as soon as we have it available. And then eventually it will also be published. But in the meantime, we'll send it out by email. We have a training course, and that's what Iga and some of her colleagues have been doing, which is the CPT2 or CPT web. And it goes session by session and shows you how to do the protocol and many videotaped examples. That is in English. We have an introductory video that's also on our website. And there is an app which is for English speakers, but it's free and it's downloadable onto the phone, and it has all the materials that are needed for a patient to do the workshop without needing paper. If they have a smart cell phone, they can download through Apple or through Google or whatever, and get to this. You just type in CPT coach, and that's from our VA, our Veterans Association, so it's free as a download. And the website, right, that CPT web, we are currently, if people let us know, we are currently allowing people in Poland and Ukraine to take that course for free. We are waiving the fee for that. That's not normally, that we usually charge for maintenance and credits and things like that. But this is very good if somebody is English speaking. It has not been translated so far into any other language, but it's got all the worksheets and the materials and writing down the name of your therapist and when your next session is. So it's a very good, friendly app that matches the manual. So what is cognitive processing therapy? It's short-term, which is very good, particularly in these kinds of circumstances. It's evidence-based. It is a specific protocol it falls under the umbrella of cognitive behavioral, but it's more cognitive. In other words, it's more about what they think about the trauma and what they think about what caused it, what the results are, what it means to them about themselves and others. You could or could not, you can do it with or without the written accounts. We found when we studied and compared with a written account of the trauma, which is how I originally developed it, we found that doing it without the account, same outcome, and we had a lower dropout rate. It's hard for people to write their accounts, which is why sometimes the exposure kinds of therapies are difficult for people to do, because this form of therapy doesn't go through all the difficult, it does not go through the difficult, excuse me one moment. We typically don't do the written account. There's certain times when it's helpful. One is if somebody has dissociated a lot during the trauma and they have dissociated memory of it. We found that high dissociators do better if they write the account, put the story back together, and then we do the cognitive therapy. It's a treatment that can be conducted in group or individual. And so I would suggest that if you've got a lot of patients, that you actually do it as a group therapy, and it can be very, very effective as a group therapy. Hang on. It's an evidence-based therapy, as Ida mentioned. And evidence-based means that there have been proper controlled research projects, and the projects have been done in a number of countries, not just by my team. So to really be considered evidence-based, other people have to do research on it as well. There have been more than 30 randomized controlled trials, which means you're comparing it to something else. In 7 different countries, and a range of traumatic events. I started working with this back in 1988 when I first developed it with rape victims. And among those rape victims, about half of them had child sexual abuse. 85% of them had had other adult traumas happen to them. So we have always worked with complex PTSD. So if you have questions about, does this work with people with lots of trauma in their histories, the answer is yes. There have also been many studies that have been conducted in practice settings, like in veterans hospitals or outpatient programs and mental health programs. We've done what is called a learning collaborative, where we teach people around our state. My state is North Carolina, where we taught people to do therapy, practitioners in mental health centers and so forth. it works very well in practice settings, not just in research settings where you've got lots of control over things. Some studies have focused now on predictors of dropout or improvement, and patient predictors, therapist predictors. They've now started looking at studies to focus on different kinds of comorbid disorders that go with PTSD, like not just PTSD and depression, which are highly associated, but also substance abuse, sleep disorders. I'm trying to think, well, alcohol abuse. Those are probably the main ones that people have looked at. OCD a little bit. So what we're doing is now seeing how well CPT works with those other symptoms and disorders, but also if you add something to it, can that be helpful? One of the symptoms that seems to last after any kind of trauma treatment, CPT or prolonged exposure or whatever, tends to be the sleep problems, which I actually think are very independent of PTSD. And take on a life of their own. So if you add a few sessions of sleep treatment after you're done, then it tends to work a bit better on the sleep symptoms. And we found, at least with one study, doing it afterwards, doing the sleep treatment afterwards works better than doing it before. I'm not sure why. I would have thought that maybe doing it before they'd do better on their PTSD. But it seems like it's afterwards. Did I skip anything? No, just, and changing the format. I'll talk more about variable length, and I will talk about, I'm going to show you some slides on group CPT. I actually started doing CPT with groups, so that's how I originally developed it. But now they're working on doing it in very short periods of time, a week, 2 weeks, that sort of thing. So the question is, how does CPT work? One of the biggest things that maintains CPT is the avoidance symptoms. And the avoidance symptoms are not, I think, not part of the core PTSD. In other words, they're not there originally, but that's how people end up coping with their symptoms. They try not to think about it. They try to put it out of their minds. They try to avoid things that remind them of the trauma. Right now in Ukraine, that's obviously not possible to avoid, but they can numb out. They might drink, because drinking would be a form of avoidance. That sort of thing could be avoidance. There are many, 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 many kinds of avoidance. So by them coming into treatment, by definition, you're already challenging their avoidance, because you're saying, we're going to work on your PTSD and we're going to work on your trauma. So we are helping them then to start to challenge their avoidance, and we give them an explanation of why that is maintaining their symptoms. Because as long as they avoid and don't think about their trauma, they're not going to change their thinking about it. They're not going to change their emotions and let their emotions run their course. And they're not going to change their behavior. They just keep pushing it away. That's why PTSD can last a lifetime if it's not treated. So the other part of CPT is that we're trying to let them feel their natural emotions. And by natural, I'm meaning the ones that we are sort of hardwired with. When you are in danger, it is natural to feel fear. When somebody is attacking you, it is natural to feel anger. It is natural to feel happy when something good happens. Those are natural emotions. Obviously, with PTSD, the negative ones, if you just let yourself feel them, they tend to go away over time, which is why the exposure therapies work, because if you keep going over it and over it and over it, the emotions decrease. And you habituate to those emotions. A bigger part of CPT is changing the interpretation about the event. So those are not what we call natural emotions. We actually in the manual call those manufactured. You have a little factory in your head that is producing thoughts about the event that maybe are not accurate. So if you change that thought, immediately it would go away, the emotion. So if you say, this is my fault, and the therapist helps you see that it wasn't your fault, then you would go, oh, it's not my fault, it's somebody else's fault, or it's nobody's fault, whatever. But then the emotion of guilt or shame would go away. Finally, we start working with the trauma itself, and then a little more than halfway through the therapy, we work on helping them look at the effects that their thinking about the trauma has had on their thinking about the world and themselves generally right now and into the future. So we try to teach them not to overgeneralize their thinking. So if you say, this group of people is bad, they're all bad. They're taking a single bad event and applying it to everyone. But if you say, I made a mistake, I must have bad judgment, then you might judge yourself overly, or I can't trust anyone, or I must have control, or I'm out of control, or I'm helpless. So those kind of going to extremes in the thinking about themselves and the world and the future. And so we work on those as well. But first you have to start with the trauma. So in the beginning of the therapy, we start with first sessions normally, like many therapies, is education. And then we move to, after just here's what PTSD is, which of the symptoms do you have? Here's what CPT is, here's what we're going to be doing, here's how you got stuck in your PTSD and haven't recovered naturally. Most people recover from traumas. I think the more traumas you have, the harder it is to recover, because you start connecting those events and thinking it must be something about me, that these things keep happening. So if you have people who are in the war, but they had child sexual abuse, now they may connect those two when they're probably not connected at all. But they're thinking bad things always happen to me. So they'll come up with those kinds of thoughts. Even at the end of the first session, we give them a practice assignment to take home and do. And that is to write what we call an impact statement. Why do you think this traumatic event happened? And why do you think that how's it affected your life and your beliefs? And we'll have them focus on areas of thinking that are likely to be disrupted with trauma: safety, trust, power and control, esteem, and intimacy. We always start, as I said, with the trauma itself. Why did it happen? Excuse me, my phone rang. My house phone almost never rings. So we start by looking at stuck points. And stuck points are thoughts that keep people stuck in their PTSD. And some examples of stuck points are, if only I had, or I should have done this, or I should have done this, and then it wouldn't happen. Now, you may be working with people who are refugees from Ukraine. So maybe they're saying, if only I had gotten my grandmother out. Not thinking that maybe grandmother couldn't travel, but blaming herself because she didn't get her grandmother out, and not thinking about the whole picture. Or I should have gone back. I should not have left. I mean, there's all sorts of things that people are going to say should have, could have, and then this wouldn't have happened. They'll say, it's my fault that I didn't get somebody out of a building in time, when maybe, in fact, they never could have gotten the person out of the building. And then when we start thinking about those overgeneralized, or what we call over-accommodated thoughts, it's things like, it is completely hopeless. I will be permanently damaged. No one can be trusted. I am completely helpless. Other people have total control. I have no control over my life. And issues with esteem, self-esteem, other esteem, and intimacy and connecting with others. So we look for those kinds of things in their impact statement and help them start to generate a stuck point log. And those are the thoughts that we're going to work on. Some of them may turn out to be true. Some of them may turn out to be what we would think of as a stuck point, keeping them stuck in their PTSD and has stopped them from recovering. All right, so a stuck point is a thought. It's not an event. It's not an emotion. It's not a behavior. It's usually a statement. Am I talking too fast or am I okay? Okay. Okay. It's usually a statement that is factually incorrect, but the person believes for some reason, out of just habit, they've been saying it a lot, so now they believe it. It sounds like truth because they've repeated it so many times. Just world beliefs are beliefs that good things happen to good people and bad things happen to bad people. It must have happened to me because I must have made a mistake, or it's not fair, or why did this happen to me? Those kinds of questions indicate their belief that there's a just world. And some people believe just the extreme opposite. Attempting to undo the event. Sometimes people go back in time and try to redo the event and make it come out differently in their imagination. So they haven't accepted that it happened, but they're trying to undo it and make it not happen. And that's where they get into if only, or I should have, or I could have. And they ruminate, which is kind of a form of avoidance, because you're avoiding what really happened and maybe how little control they in fact had in that situation. But they are thinking about all the things they should have done differently. We should have left earlier. We shouldn't have left at all. We shouldn't have, those kinds of things. I should be doing this. So the thought that they're having, the stuck point they're having, leads to negative emotions like guilt, rage, fear, etc. Now, I said anger is a natural emotion, but if you're focusing it on yourself, I'm so angry at myself that I did this, or being angry at the wrong person, then you're going to hit, the thoughts are going to lead to all the same kind of emotions, except they're going to be more manufactured and not the natural emotions that came from the event itself, the traumatic event. And you can have fear be a primary emotion, but it also can be a secondary one based on your thoughts, like I'm always in danger. Every time I hear a loud noise, I think I'm about to die. So they have a fear response, even if they're actually safe. Changing the thought changes the emotions. Except, as I said, those natural emotions. And natural emotions like grief need to run their course. And sometimes people are so caught up in guilt or self-blame or I got out and someone else didn't, would be an example, that they're not grieving, they're feeling guilt instead. And so those stuck points are keeping them from feeling the natural emotion of grief. So CPT is going to help people to examine their thoughts, look for the facts, and then adjust their thinking as needed. And we don't try to get people having a rosy picture, because of course that's not reality. What we want is to look at balanced thinking and not go way overboard one way or the other. So they're going to learn the connection between events, thoughts, and feelings. And this is something that a lot of people haven't been taught. They don't think about it. But there's a difference between an event and a thought. And people often will think they're because they think it makes it true. So the event is the traumatic event. My grandfather was killed. my thought, I should have gotten him out. And I feel guilt. So it'd be A, B, C. If you're doing CPT with the accounts, then the patient would write a detailed account of the worst traumatic event. And that happens in session 4 and 5. As I said, our training program right now is not teaching that. The online course is just teaching CPT without the written accounts. But if you were to do that, then that's where that would fall. It's in the manual as one of the chapters. After the main protocol. Sessions 5 through 7, we focus on teaching them to ask themselves questions. We've been doing Socratic questioning, which I'll talk about. And then we teach them to ask questions for themselves. So we teach them to start doing Socratic questioning for themselves. The goal is for them to take over as the therapist. And so we're teaching them the skill of asking questions. Does my thought make sense? With the challenging questions worksheet. And once we've done that and they've gotten some practice at that, they always do the practice assignments between the sessions. So even if we were doing the therapy in a week or 2 weeks, we would still have them do practice assignments between the sessions. They may not do as many, obviously, but then between the sessions, we want to give them enough worksheets or have them use the phone app. Now, as I said, that's only in English right now, but it'd be nice to see that translated. Learning about patterns of faulty thinking comes next, and that's the idea that people tend to have tendencies to think in certain ways. Some people jump to conclusions. They hear something and they just jump to some meaning that they don't have the facts for. Some people engage in a lot of mind reading. That person looked at me funny, they're dangerous. They're mind reading that person's intentions. Those people must not like me, would be mind reading. Emotional reasoning is, I feel fear, so I must be in danger. They go backwards from how they're feeling. Now that feeling may have been conditioned. So every time you hear a loud noise, you jump. But then you say to yourself, I must be in danger. And they run away and don't learn that that was just a car noise. So people will have tendencies to do those things and they can get stuck in those patterns because they avoid them, they don't get any correction or any corrective information. So once people become aware of their own tendencies to think in certain ways, then they will start to notice that they're doing that. And I'm going to show you examples of all this. Then we go to challenging beliefs worksheet. And the challenging beliefs worksheet is where we put all the worksheets together and use that for the rest of the therapy. And we have simplified versions for people with low literacy. We have various other ones that are not even in the manual that I can share if people need them. If people have trouble reading across columns, we have one that's more vertical. It's more like an outline where they would ask themselves the questions. But we're basically, it includes the ABC sheet, it includes challenging questions, problematic thinking, and then we add in the final view is, what else could I say to myself? And if I said this and I believe it, having looked at all the rest of this, now how do I feel? And what you're looking for is a change in their emotions, either less emotion or a change in emotions. Sometimes people going from blaming themselves to blaming the actual perpetrator, or moving from guilt to grief, as I said. Okay. So then we use that same challenging beliefs worksheet over the last sessions, and we're looking at those overgeneralized, what we call over-accommodated beliefs about self and others. And then we have specific handouts that we give them. We call them modules. They're just handouts about safety, trust, power and control, esteem, and intimacy. And each of those themes can be related to yourself or other people. You might have issues with self-safety. I can't protect myself. Other safety would be other people are dangerous. And if you said some people are dangerous, that would be a balanced thought. If you said all people are dangerous, then that would be a stuck point. Babies are not dangerous. So if you can find one exception, you can't say all. Trust would be self-trust or trusting other people. And we have to help them understand there's lots of different kinds of trust, not just trust with your life, but trust with a secret, trust that someone will be supportive, trust can be all sorts of things. And we have a trust star that helps them tell the difference. Now, all of these are multi-dimensional, and we want to teach them that emotions can fall on a continuum as well, from a little to a lot. And when they come in with PTSD, they're feeling everything a lot. And what we want to do is get them back to feeling things in a more balanced way. Power and control can be, again, about self or others. I'm helpless. I must have control. People with obsessive compulsive disorder have control issues. Sometimes people with alcohol have control issues, but they're saying because I don't have any control, I might as well have no control. It doesn't matter what I do. But then there's the issue about other people controlling you or trying to control you. And there is certainly a lot of ways in which we don't have control over our lives, but we do make a lot of choices every day that we do have control and nothing bad happens. Esteem is self-esteem, or the regard that you have, the esteem that you have for other people. And that can be men, it could be women, it could be Russians, it could be, depending on which war you happen to be in at the moment, it could be about a particular ethnic group. Anybody who is like your perpetrator, you might overgeneralize to the entire group. And then finally, intimacy. Self-intimacy is your beyond self-esteem. It is about your sense of self. It is about your sense of your values. What do I want to do with my life? If I didn't have PTSD, what would I spend my time doing? What are my goals and values and tastes and things? So, because if people have had PTSD for a long period of time, they may lose that sense of self. So self-intimacy is developing a relationship with yourself. Other intimacy is the whole range of relationships, from acquaintances to your intimate partners, your relationship with your family, with friends, with children. And so some of those get disrupted with PTSD as well. And then we end the therapy by having the client rewrite that first impact statement. Now that you've gone through the therapy, now why do you think this worst traumatic event happened? And we always focus on the worst first, so we try to get them to focus at the end, again, back on that first one. And now, why do you think it happened? And what do you say to yourself about it? And what do you think about all these other issues about yourself and the world? So originally, we conducted CPT as a group treatment. So we know it works as a group treatment because that's how it started. And then when I started comparing it with prolonged exposure, I had to make it an individual therapy. And we did a study not too long ago where we found out that generally individual does work better than group. If people have head injury, it's particularly important that they do individual rather than group, because they can get lost in the group, and you may have to pace it a little different. But group can work very well. When it's done individually, you can do the accounts. As I said, we typically don't. but we do a lot of Socratic questioning with or without the account. Without the account, the therapist and the patient are going to spend an extra session with the ABC sheets. So they have 2 sessions of ABC sheets. And the therapist's form of therapy is Socratic dialogue. And you're going to use that stuck point log. And then we also have 1 extra session that we didn't have when we had the accounts, where they do the challenging beliefs worksheets on their assimilated, their trauma-related stuck points, and then move on to those themes. More recently, one of my colleagues, Tara Golofsky, started looking at flexible or variable length CPT. That doesn't focus on a specific set number of sessions. You'll see that more in the research where we compare CPT to something else and they'll do a fixed number of 12 sessions. Variable length doesn't focus on how many sessions. It focuses on what it takes to get better. Now, we're going to keep going through the therapy as usual, but some people we're finding don't need 12 sessions. The average with non-military tended to be about between 7 and 9 sessions till they got to what we call a good end state. And in the manual, we have the PCL5, that's the PTSD checklist. You should give that every week so you can take their temperature. It's like going to the doctor and having them check your blood pressure. You want to see how their symptoms are doing every week. Even if you see them twice a week, you still would give this once a week just to see how they're doing. If they have a PCL below 20, that's probably in the non-PTSD range. About a 33 is the cut for most probable PTSD. And the PCL only takes about 5 minutes to give. So if you can give that before the session and score it, you know how they're coming and whether they're still stuck, whether they need to, if they have particular symptoms to work on, if there's stuck points hiding in some of those symptoms. We found that the military veterans took a little bit longer on average. They, because of their military training, they tend to get trained into some stuck points. I am responsible for my men. If anything happens to one of them, it's my fault. So they're trained to have stuck points. Never leave anyone behind. That's one that American soldiers are taught. And so if you had to leave someone behind, now you feel guilty. So they're already kind of trained in stuck points that once a trauma happens, that's related to one of those, they get pretty rigid about it. I must stay vigilant all the time. I can never let down. And they're very reluctant to give up those hypervigilance symptoms. They'll go marching around their house, protecting their house, even in a peaceful area. And so military people tend to be a little tougher to treat than civilians. During the pandemic, we moved to using telehealth, doing it by Zoom, and it works very well. If someone has a tablet or even using just the phone and doing FaceTime, we've been able to do the therapy very well. We had already studied it before the pandemic, fortunately. And people have even done group therapy with Zoom. They're all on the screen, and the therapist is on the screen as well. And then you would try to get them, if possible, to email the worksheets to you so you can take a look at them. So we do telehealth, and there are systems in the US now where they're moving a lot to telehealth because you can reach people who live too far away, who live in rural areas, but do have access to a telephone or an iPad or some kind of tablet or a computer where you can do, if they've got an internet connection, they can do it. So we're doing a lot of telehealth. We also are doing intensive outpatient treatments within a week or two. And when we get to the end of this, I will show you a link that you can listen to if you can speak English. You can listen to a whole course of therapy that was done in 10 sessions of CPT. It was recorded and done as a podcast. a reporter went and flew across the country to be treated by one of our CPT therapists. And they did it Monday through Friday. Monday through Friday, she did it. She had 2 weeks to do it. And she then recorded sections of it and has a 1-hour podcast. And it's very interesting for clients to listen to, because they often don't know what therapy is going to be like. And it's also good if you're interested in CPT to listen to it, how, from a patient's perspective, how it goes. So CPT uses a combination of progressive worksheets and handouts. So they're doing the work on the worksheets and they bring that into the session, and then you're processing it and asking them questions about it. And we tell them, you haven't learned this in school. We don't learn balanced thinking in school. And chances are our parents didn't teach it to us. So when you have traumas happen to you, your thinking can become unbalanced and can keep you stuck in your PTSD. In fact, we have a self-help manual that we just submitted for final submission for publication, and we're calling, the name of the book is called Getting Unstuck. So it is a self-help CPT manual for people who can't get to a therapist. That it'll be another 8 months before it's actually published. So we're trying to help them change their thoughts from extreme to more balanced, and to help them reduce those negative emotions and then negative behaviors that go with those emotions. The therapist style is to be Socratic. That means not to try to convince them to change their mind. You can't do that. If somebody says it's my fault that this thing happened, and you try to say, no, it's not your fault, they're going to just think you don't know what you're talking about. So even if you have the answer in your own head, it doesn't help to try to convince them. You have to be kind and curious. And what was it like? How did you come to that conclusion? Why do you think it's your fault? Or why do you think it's this person's fault when you know clearly it wasn't? Or you're pretty sure it wasn't. You're going to ask questions. And you have to take I'm a superior position, but like, I don't know what it's like to be you in your life. So you're going to be kind, you're going to be curious. You can ask almost any kind of question if you do it in a kind way and a curious way, like you really want to understand them, which of course you should really want to understand what it's like to be them, and how they've always thought, and now what disrupted that thinking, what their automatic thoughts are, etc. Everybody's unique, but we're going to run across a lot of stuck points that are very similar, even across different kinds of traumas. Okay, we'll take a break in about 5 minutes. We'll take questions in a minute. I'm just going to show you a couple of examples of worksheets. This is the ABC worksheet. So A is, it's called A because we said originally it's activating event, the trauma that something happens. B is the stuck point. I tell myself something. And C is I feel something. That's your consequence. So it's A, B, C, your belief, or your stuck point. And then I feel something. So they write in, and we don't give them a lot of space because we don't want them writing paragraphs. This is a sentence. I was raped by a soldier. I tell myself I shouldn't have been outside. I feel shame. Then the therapist starts saying, okay, why were you outside? Well, I needed to get food and water. We were running out. So how did that make him rape you? Well, it doesn't. He took an advantage of an opportunity, but you have to help them reason through that she didn't cause it. He was doing it because he had the opportunity to do it, and he did it. She was the occasion for it to happen, but not the cause. If he wasn't a rapist, he wouldn't have raped her. So you could say, had you ever been out before to get water? Yes. Were you raped every time? No. Had other people gone out to get water? Yes. Were they all raped? No. Okay, so it happened on that one occasion. Someone happened to be there. So what else could you say to yourself? I happened to be there when the rapist was there, when that soldier who wanted to rape someone was there. He looked around, thought he could do it, and he did it. If you say that to yourself, if you say that I wasn't the cause, he was the cause, then how do you feel? So you're trying to get them to think about what could you say to yourself when that thought comes up? And then how do you feel? So this is just the first handout and the first way. The focus here is just to teach them to notice there's a difference between events and their thoughts and their feelings. And then we focus, we don't tell them to change their feelings. We validate their feelings. Yes, I understand how you feel this way. If I said this to myself, I would feel that too. Let's take a look at what you've been saying to yourself. And your reasoning, let's put it in the context that it happened in. So here's an example. I was in a car accident. And the person comes into therapy and says, it's my fault that my friend was badly injured. And he feels guilt. And then after they've talked about it for a bit, about how is it your fault that your friend was injured? Tell me about the car accident. What happened? Well, my friend was driving and maybe I should have been driving. Maybe I should have made her make sure she had her seatbelt on. She didn't have her seatbelt on. Did you have the option? Did you say anything? Yeah, I said something. And she said, no, I don't want to mess up my clothing. So are my thoughts and be realistic? I don't know. Maybe I should have insisted that I drive. But didn't you say it was her car? Yes, it was her car. And she said no. So would the accident have happened anyway? Possibly. You know, if you were hit by someone else, you driving might not have changed the outcome. But you'd ask that in a question form. And then you'd help them go through their reasoning about why it's their fault. And even if they had done that, would that have changed the outcome? Maybe not. What can you tell yourself on such occasions in the future? It wasn't my fault. I asked her if I could drive and she said no, it was her car. And I couldn't make her wear her seatbelt. So not that if I had been driving, the event wouldn't have happened. So sometimes just even doing these ABC sheets, you start to see some shift in their thinking. This is the ABC sheet in Ukrainian. So are there Ukrainian listeners here? They can read it. The challenging questions worksheet. I'm not going to go through all these because it's time for the break. Before I start this, let me take a couple, just a minute or two. Do we have questions at this point? I don't want people to have to wait for 2 hours to ask questions. You can put them in the chat and then it can be translated maybe. Are there any?
Czy można przypomnieć, gdzie można zobaczyć?
Could you remind us where we could see this example on YouTube?
I'll get to that at the end. That's on the last slide.
Okay.
And I'll pause on that while we take questions.
Super.
So people can see that. Yeah.
Super.
It's a podcast to listen to. It's not a YouTube. But you can Google it very easily. Any other questions? Okay, why don't we take about a 5-minute break? Would that work for everyone? And then we'll come back. I'll go through the worksheets, and then I'm going to talk a little bit about, I'll walk around the range of worksheets. Then we're going to do CPT. I'm going to do a hypothetical. If you only had 1 or 2 sessions with someone, what could you do? And then I'll talk about doing CPT in groups. If you're not interested in that, we can just stop and you can have those. The last slide is the one that's got that. This American Life. That's what you would be Googling, This American Life 10 sessions. But we will go, I thought since some of you won't have seen the group materials, you might be interested in that. So we take 5 minutes. Okay, break. Yes, okay. Ika, can you read the questions? And then tell me.
Tak. Do you have any thoughts on when it is better to use the CPT and when PE?
Mostly we try to give people a choice. We describe both therapies. If you can do both, you describe both therapies and let them make a choice, because whichever one they prefer is what they're more likely to invest in. If someone is illiterate completely, it's a little harder to do CPT because we're asking them to fill out, I'll show you some simplified worksheets, but if they're completely illiterate, sometimes it might be easier to do PE. If they only have fear, I think the exposure work can be good. Most in the US, most in the BA system, most people choose CPT, to be perfectly honest. They don't like doing exposures. But I think there's times, but as much as possible, we like to give people a choice. We have done, there was a study that was done with CPT in the Congo, where everyone in the group was illiterate. They couldn't read or write at all. They had no paper, no pencils, they had nothing. And they had to do the whole therapy verbally. In fact, the therapists only had maybe 7 or 8 years of education. And they had to teach them to be therapists and then to do CPT. And it worked very well. So it's possible to do it with people who don't have a high literacy. We just have to adjust it. And we actually have a manual for the Congo that people have adapted for other third world countries or places where there's really high illiteracy rates, low education. Any other questions? We know that CPT works better with guilt and shame. It works a little bit better on suicidal ideation. They both work on that, but CPT works a little bit. We've done follow-ups. I did a study where we compared PE and CPT, and then we did a long-term follow-up that was 5 to 10 years later. The good news is on neither of these therapies did people relapse. Even the people who had many traumas, and we didn't rule out people for any of comorbid disorders. But there were a few differences. As I said, there was a difference that lasted all the way to the long-term follow-up. The guilt and shame were better treated with CPT. I'm trying to think, there was, and hopelessness was treated better with CPT. And there was a measure of the suicidal ideation. They both improved, but CPT work improved more. So But if somebody has a straight fear reaction, then I think it would be just a matter of choice, but I think the exposures can be very helpful for that. Any other questions? Okay, I'll go ahead then. Am I talking too fast? Did you get any feedback? Iga? Am I doing okay? Am I talking too fast or am I okay?
Everything is fine. Thank you.
Okay. This is an example of the challenging worksheet. It's actually on one piece of paper, but for the slides, it's divided into two. So we asked them to put in a belief or a stuck point. It's my fault that whatever happened. And so you'd say, what's the evidence for and against? So what's the evidence that it's your fault? What's the evidence that against that idea? Well, and sometimes we'll ask them what their intent was. What did you intend in that situation? And if you don't have intent, you shouldn't have blame. You might have played a role in it, in which case you might feel regret, but a lot of these events are unforeseeable for someone. So they really shouldn't be having blame for something they didn't intend to happen. So we're looking for the evidence against that idea. Is your belief based on habit or facts? And what we mean by that is, have you gotten into the habit of just saying that stuck point over and over and over again so that it sounds like truth? Or is it actually based on facts? Now, you've been doing some Socratic questioning with you to figure out what the facts were, what the context was of that situation they were in, what choices they had, what options they had available to them, not something they thought about later, but what actually did they have? How much time did they have to make decisions? So you're going to pull the facts out that are important for that. We're not going to get into gory details about a trauma, how it looked or smelled or anything like that, but just the facts that we need to help them look at their stuck points. So what are the facts? Or are you just in the habit of saying that stuck point? In what ways is your stuck point not including all the information? If you left out that other people were also there and you're blaming yourself for making a decision and the other people were also making the same decision, then how is that your fault? So you'd be leaving out some of the information. Maybe the fact that you didn't have any choices, you're leaving out. And you're trying to assume that maybe you had more choices than you did. A lot of people have trouble with the idea that they didn't have control or that they don't have control over everything. Are you thinking in all or none terms? That means either or. If I had done this, it would have worked. If I trust someone, they will hurt me. That's pretty much an either or statement. Does the stuck point include words or phrases that are extreme or exaggerated? Now, on this sheet, we asked 10 questions. They don't fit every single stuck point, but we give them a bunch of questions so that at least some of them will help loosen up their thinking. So are they using words or phrases like always, forever, never, need, should, must, can't, every time? So these extreme words are ones we look for, and they're often with those over-accommodated stuck points, the ones we deal in the second half of the therapy. It will always be this way. I will never recover. In what ways is your stuck point focused on just one piece of the story or one piece of the traumatic event? Sometimes they'll have their flashback is like tunnel vision. So they're only seeing a little slice and they're not seeing the whole picture, and they're not seeing themselves in the context of what happened. The other people that were there, what choices they had, and they're only focusing on one little slice of the story. And that may be what they're stuck on, is that little tiny piece. I had 5 seconds to get away. Why didn't I do it? Well, maybe they were frozen. Maybe they really couldn't get away in 5 seconds. or maybe they couldn't go run back into a burning building and save someone. But they're focusing on that they paused and they didn't go do it, even though it would have been impossible to do. Where did this stuck point come from? And is this a dependable source of information on this stuck point? Now, this sometimes is an important one for people who have child abuse, because their parent is always blaming them for their abuse. It's your fault that I hit you. You're stupid. You made me do it. Battered women often have that also. And so the question is, where did they get that stuck point from, that you're stupid, or everything is your fault, or bad things will always happen to you? Where'd that come from? Now, sometimes the stuck point comes from themselves and their desire to get things back to feeling their desperate attempt to make themselves feel safe. They will assume, if only I had done this, I would have been safe, or my family would have been safe if only I had done this. And so they come up with the stuck point themselves. Is this a dependable source of information on this stuck point? Not are you dependable as a person, but on this stuck point. If you have PTSD, you've been thinking it through your PTSD glasses. How is your stuck point confusing something that is possible with something that is likely? Now, this is a good question to ask when you're talking about future safety. I will always be in danger. Well, what's the probability that you will always be in danger no matter where you are? You're a refugee in another place where there's not a war going on. Are you safer here than there? Now, even in the Ukraine, there's some places that are safer than other places. It's not all uniformly dangerous. There are certain places that are much more dangerous. So we're talking that when we talk safety, we're often talking something that's highly probable or something that is less likely. And so even when they get into a low probability, they continue to think that they are still in imminent danger. They are in actual danger all the time. They can't get out of that mode. In what ways is your stuck point based on feelings rather than facts? That was what I called emotional reasoning. Because I feel guilty, I must have done something wrong. Because I feel fear, I must be in danger. So I run away, and then I think, I dodged that one. And they don't understand that maybe they were safe. Maybe they weren't really in danger. So they don't get any corrective information. In what ways is the stuck point focused on unrelated parts of the story? Examples I see a lot of is a rape victim will say, I had a drink. Your drink made that person rape you? Might have made them more vulnerable or made them a bit more at risk. But how many times have you gone out with your friends to a bar and had a drink? Many times. Were you raped every time? No. Were all your friends raped? Were your friends raped that evening? No. So maybe the fact that you had a drink wasn't related to why you got raped. So think about what they're telling you in terms of the story and what they're focused on. It may not have anything to do with why the event happened, but they've latched onto it. I had one person who somebody broke into their house and beat them up and stuff. And it was like, I don't know, 2 o'clock in the morning or 3 o'clock in the morning. And she would stay up until after 3 in the morning because she had it in her head that 3 o'clock is dangerous. That's pretty unrelated to what happened, but totally focused on almost superstitious behavior that if I just stay up past 3, I'll be safe. So sometimes the things they get stuck on don't make sense, but it does to them because they've focused on an unrelated part of the story and not what caused the event, but just what happened. Okay, so then we go from focusing on one single stuck point to focusing on patterns of thinking. And everyone tends to have shortcuts in their thinking, automatic habitual thoughts. And a lot of people learn these from their parents. They've learned them through other events in their lives. But we ask them to go through their stuck point log and see if they have any examples of jumping to conclusions or predicting the future. If I do this, bad thing will happen. If I trust someone, they will hurt me. That would be predicting the future, wouldn't it? Now, some stuck points are going to fit under 2 or 3 of these categories, but many people jump to conclusions without any evidence at all. Exaggerating or minimizing a situation. In other words, exaggerating would be saying, I had a much bigger role in that situation than I in fact did. Like I had more control than I actually did. Sometimes people try to minimize something about the situation. So blowing things way out of proportion or shrinking the importance inappropriately would be exaggerating or minimizing. There's examples in the book and on the online course. Ignoring important parts of a situation, ignoring that person was much bigger than you, they had a gun, you were trapped. I mean, there's so many things that people tend to ignore. Oversimplifying things is good, bad, or right, wrong. In other words, they just fall into simple categories instead of falling along a continuum. So these tend to fall with those later themes. Trust, not trust, control, not control. Overgeneralizing from a single incident. In other words, a bad thing happens to you, and then you think this will always happen to me. Now, a lot of the people who come to therapy have had a number of traumatic events. So it may not just be the war. It may be the war and some specific trauma that happened within that, but they may have had a history of trauma before that. And so they may have already started with negative views of things and just assume I will always have bad things happen. In fact, they will connect dots between negative events and assume there's a pattern there. And they may be totally disconnected and they're leaving out all the good things in their life up until then, or all the neutral days where nothing at all happened. More days than not. Of course, it's a little different when you're in the middle of a war zone or if you're in East Ukraine right now or South Ukraine right now. But most of the time, we have lots and lots of days that are very neutral. Nothing bad happens, nothing good happens. It's just a day, but they count. And so people get out of proportion when they only focus in on a couple of negative, horrible days. Yes, they were truly horrible, but they may be ignoring some really wonderful days too. The day they got married, the day their child was born, the day that something else happened. They forget about the good stuff because they're only focusing on the negative. And what we're trying to do is get the whole picture. Mind reading is you assume people are thinking negatively of you when there's no evidence for it. We have to teach people how to actually ask, what did you mean by that? Instead of assuming that they don't like you or assuming that they're out to harm you. And then emotional reasoning, again, is similar to what I talked about before, which is using your emotions as proof of your stuck point. I feel fear, so I must be in danger. I feel guilty, so that's proof that I did something wrong. So it's reasoning backwards from their emotions and using that as proof. And some people tend to do that a lot. Now, this is the whole challenging beliefs worksheet, the whole thing. And I've got the example of the car accident in here. So over here, we've taken the ABC sheet and we pushed it all the way over to the left side. That whole thing that took up the whole page before. Now we have the ABC sheet. Here's the situation. Here's the thought or the stuck point. And here are the emotions. Here's A, B, and C. I was in a car accident. And my thought is, my stuck point is, it's my fault that my friend was injured. And I believe that. Now we've changed it a little bit because we're further along in therapy. We're up to about session 6 or so. How much do you believe it now? Now, if they've been budging on it, they might say 90% or 80%, I believe it. But this person says 100%, and I believe that. It's still my fault. And then we ask them what emotions they feel and ask them to rate their emotions. We give them an emotion wheel, and that's in the book, or it's in the manual. So they say, I feel guilty 100% and I feel sad 90%. And here's the challenging question sheet. You just saw it right after the break. They were full sentences. Now we just have a little short stems. They can go back to look at the whole page, but we wanted to get everything onto one worksheet. So what's the evidence for? Sorry. I'm going the wrong direction. Okay. What's the evidence for? If I was touching my mouse, if I had been driving, I would have swerved. That's why they think it's their fault. What's the evidence against? It was her car. I don't know if I could have avoided. So this is after the therapist has been helping. Obviously, they're saying, do you know if it would have had a different outcome? How do you know you could have swerved and gotten out of the way of the car? Is it a habit or a fact? The person says it's a habit. Are you not including all the information? Well, this person was initially ignoring oncoming car has hit us. All or none thinking, it's all. Yes, I could have saved my friend. It's all my fault. And there's usually, when they say it's my fault, usually there's the hidden word all in there. Extreme or exaggerated, yes. Are you focusing on just one piece of the story? If I had been driving, I keep thinking if I had been driving, I would have swerved and saved us or saved her. Who's the source of this information? Me. I think I'm a good driver. So this person was convinced it was their fault. Their friend was injured because they weren't driving. So confusing possible with likely. Yeah, it's possible that I don't know that I could have swerved out of the way of the oncoming car, the car that was coming toward us. Based on feelings or facts, don't know if I'm doing that. They can leave things out if they need to, or just say not applicable. Did you focus on unrelated parts of the incident? Yes, the other driver caused the accident. That's a pretty big thing to leave out. See, he started with, it's my fault that my friend was injured. We didn't even know that the other person caused the accident. And then when they looked through the patterns of problematic thinking, jumping to conclusions, yes, I was jumping to conclusions. So it's all about this stuck point. I was minimizing the other driver's role in it. Ignoring important parts. My friend didn't cause the accident. Are you oversimplifying? Yes. Good, bad, right, or wrong? Yes, I'm oversimplifying it. It's my fault. It's all my fault. Yes. I was overgeneralizing. Yes, I always insist on driving now. So this is one of the outcomes of having the trauma happen, that they always insist on driving now because they were convinced it was their fault. Mind reading, no. Emotional reasoning, because I feel guilt, I assume it must be my fault. Then this is the one thing. Now they've had all this other stuff and they've had practice with all these other steps. And now they're back to doing the ABC sheets again, doing more challenging questions, problematic thinking. Now, what could you say instead of, it's all my fault that my friend was injured? The accident was unavoidable. We were hit by a drunk driver. How much do you believe that? 90%. All right, so now re-rate how much you believe that it's all your fault. Oh, 20%. They don't go down to 0 necessarily. I think I still think I might have been able to swerve. And now how do you feel? They went from 100% guilt to 20% guilt. Sad stayed the same. They're still sad that this person is injured, but it's not sad that they caused it, but it's more like sad and grieving that this person is so badly injured. Questions about this worksheet? Yes, no? As we go, if you've got questions, just go ahead and put them in the chat so somebody can read them when we get to that time. Okay. This is one for people who have low literacy. We use an ABC sheet that's a little more expanded. Oops, that one bubble, a little face moved over. So here's the event. Here's the ABC sheet event. And they would tell you the event. You'd write it down in here. What's your thought about it? What are you saying to yourself about why it happened? What are you feeling? Sad, scared, angry, whatever. Does it make sense to tell yourself this? And you would go through your questions of them and to find out the context and what options they had. Is the conclusion too big? What's the real evidence? If we were in a court of law, would they say this is all your fault? And sometimes we will use court of law just as an example. Would they say that you should be punished because this is all your fault or whatever? And so what's the actual evidence? You can do this for any stuck point. What's the actual evidence that you are always in danger now? What's the actual evidence that that you will never recover or that you're permanently damaged? What can you tell yourself in the future? What's a more balanced thought? And then how does that feel? Now, this would not be for somebody who's totally illiterate, but this is somebody who has low literacy and you can help them with it or have a family member help write that in. We've used this therapy typically down to age 14 without any adjustments at all, without doing this worksheet. We can use that big worksheet I just showed you. We can use this with 14-year-olds and they do very well with it. A little bit younger and you probably would need to be changing it a little bit. So I wouldn't necessarily assume you have to change it with an adolescent. If they can read and write, they can get those other concepts. You might have to explain some of the words. But I know people have done this with 11 and 12-year-olds even without adjusting it. Usually they're pretty good, smart 11 or 12-year-olds, but here's my hypothetical. If I only had 1 or 2 sessions and I contacted a friend of mine who he just retired from the military. He was a colonel now, a psychiatrist who deployed to Afghanistan and he was doing CPT. I went up to the fort he was working on. He was in charge of all their mental health services. And these were people who were mostly going to Afghanistan. And he deployed to Afghanistan and he had me come up to the base and give a CPT training, and had them all practicing it like starting Monday. Change your cases over to CPT. And that's what they did all day, every day. They did CPT with people with PTSD. So he went over and I contacted him and said, well, how much time did you have? He said, sometimes I could do the whole course of therapy if I was back on base, but if I went to a forward operating base, I might only have a couple of sessions. So I started thinking about how could you use CPT if you only had a couple of sessions? Well, you'd ask them what happened, which event causes the most nightmares, flashbacks, avoidance, which one do you try most not to think about? Which one haunts you the most? In other words, you're trying to find out what's the index event, what's the worst event. You want to always start with that because you can always move to other events. If you start with a lesser event, then you still have to treat the worst one after that. You could either do a verbal or a written impact statement with them. If you had 1 session, you can do it verbally with them. What does it mean on why the event happened? What does it mean to you? Why do you think that event happened? If they have a session between, you could have them write their impact statement and come up with and help them figure out their stuck points that are keeping them stuck. Any other thoughts or emotions that are bothering you? Look for guilt, erroneous other blame. Is it mostly fear? Is it anger? Is it what's the primary emotion they're having? And if possible, if they've got several stuck points, I don't know if you have this term in Polish or Ukrainian, but a linchpin, you pull the pin out and everything falls apart. A linchpin. Is that a concept? You're looking for the most important stuck point. The most important stuck point you can find. It happened because, and you saw that on that worksheet, I should have been driving. I would have been able to swerve. That was his linchpin stuck point. You put that on an ABC sheet. You ask Socratic questions about it. Okay, tell me about, why do you think the event happened? And tell me more about why you think that's the case. Who else was there? Who was in charge? How much time did you have to react? Why did you make the decision to leave your grandfather behind? Well, he was 64 years old, and they were keeping people who were 65 in Ukraine. So did you have a choice to bring him out? No. All right, so how did you think it's your fault that you didn't bring him out? Did he want to come out? No, he wanted to stay. Why did you leave? Because of our children. I had to protect the children. Sounds pretty reasonable to me, but why are you blaming yourself because your grandfather was killed? Who had the intent? Who killed your grandfather? How is this your fault for not getting him out? He wanted to stay, and he was not over the age that he could leave easily. So you want to look for an opening to help them in their thinking. If you are working in an environment where you don't have much paper to use, we actually had a clipboard where you put papers on and clip them. We actually had one with an ABC sheet written on it, and you could use a marker, a erasable marker. We had somebody who laminated it, or they put it in a plastic sleeve, and you could keep using the same ABC sheet over and over again. You just erase it, try a new one, and then have them come up with an alternative thought. How do you feel if you say this when they come up with a more balanced thought? Can you practice saying that? That's what I would do if I only had 1 or 2 sessions. So you're not going to get into all those things about all those other themes, et cetera. You're not going to go through every single stuck point. You'd go for the biggest stuck point they've got. It might not resolve everything, but you might at least lower their symptoms some and give them fewer nightmares. Questions before we move to group? Group is good because it's not just the therapist, everybody else can be helping too. When they did the study in the CPT in the Congo, in the Democratic Republic of Congo, the women did it as a group therapy, and they helped each other. We've seen that with veterans also. They can pick out another person's stuck points faster than their own. And sometimes they have more credibility than the therapist, because maybe they can say, what are you talking about? You couldn't have done X, Y, and Z. You couldn't have gotten there that fast. You couldn't have seen over that next hill. So sometimes having people in the group to help them look at their stuck points can be very, very helpful. Because and then come back to them. We try to do it when you have a whole group of people, you try to do it in 90 minutes, an hour and a half. 6 to 8 people are ideal. I've seen a lot of therapists who have done it with 12, but they really knew how to do CPT, so they could manage it. If it's too small, if you only have about 3 people, if you have one person quit, then it gets too small and it starts being individual therapy with 2 people there. Large groups are going to have more assignments to manage. So it's helpful to have more than one person helping manage it. The expectation is that you're not going to get into trauma details in the group. These people all have PTSD, so you're not going to do exposures with them. They're not going to talk about all the gory details of the trauma. So they may just know this person witnessed someone being killed. This person feels this person was raped by the soldiers coming through. This person had this happen. I mean, they may know generally what it was, but they're not going to hear all the details. If it's possible, 2 group leaders is optimal. Even in the US, that's not always possible. Frankly, it's often not possible. But if you have a student who could help, that can be very helpful, or somebody who has been doing some volunteer counseling, they might be able to help as a second person. So one person can collect and review the handouts or their homework, their practice assignments, and hand them back while the other one is conducting the session. Or they can collect and share the assignment between sessions. It just makes less work than if there's one therapist there. And people without professional degrees can learn how to do CPT. As I said, we had people with 7th, 8th grade educations learning how to do CPT in the Congo, so we know it's possible. So you can actually train somebody to work with you as sort of junior therapist. It's a closed format, which is why there's no big bar there. That means because it's very systematic, this therapy, you're teaching them the ABC sheet, and then you're teaching them that, they do the impact statement and the ABC sheets and the challenging beliefs or challenging questions, and then the problematic, and then they go on to the next things. You can't just have people drop in and drop out. And usually one of the things that happens is they'll set up rules about if you miss so many sessions, you can't come back because it's too disruptive to the group. Sometimes they'll make up the rules about trying to be on time or letting people know if you can't be on time, so everybody isn't worrying about you. We try to do it if possible twice per week. The faster you do the therapy, the lower the dropout rates. If things drag out and you're only doing it occasionally, it's less effective and people are more likely to drop out. Often that's not possible to get people together. It's often not possible to get people together more than once a week, but if it is, it's lovely if you can do it twice a week. Collecting the measure. One therapist is going to collect and review, mark on the graph to hand back their measures, their PCLs, and you chart them out so you can see how people are doing. The thing you got to manage with groups is you might have somebody who's avoiding in the group and they're not talking, and you want to bring them involved. It's the same thing of anybody who's done group therapy. You may have somebody who's dominating and talking too much. Well, why don't you count to 10 and see if someone else jumps in? Or let's give someone else a turn first. You have to be careful about that so you're not insulting them because they might be just very eager, but you have to manage the group. But you also want them to see that they're all doing better. You might ask them to write on the back of the PCL on the piece of paper why they said yes to that item. Is there a stuck point there? You want to graph their progress, which is part of the book. CPT has the same session schedule as individual CPT. So you're not going to assign traumas. We do keep them doing the impact statement. They don't read them out loud in the session. They may break into pairs if it's a big group and talk about it with each other and then come back and say what they learned. Or the other option is just to talk about common stuck points. How many people had something in there about trying to undo the event or make it not happen? Or how many of you had a safety stuck point? Give me some examples. It's helpful if you can have a whiteboard or a flip chart, or even just a big pieces of paper you can put up on the wall. If not, even just a little board that you can have in your hands so you can share it with everybody so they can share examples. The members are responsible for the work of the group. And their role is the therapist's role is to create the structure and facilitate the group. You got to keep the rules and the boundaries, no getting off topic for periods of time. You always want to not just focus on one person and resolve that one person's stuck point. You want to bring it to the group level and have them, how many of you have that same stuck point or something similar? All right, let's work on an ABC sheet on it's my fault because, or it's all my fault. How many of you actually have the word all in there? Now, let's think about that. Let's think about that word fault. Did you intend? And have them discuss that. What about all your fault? Was anybody else there? Is it anybody else's intent? So you're looking for similarities among the members, and you want to keep your eye on that engagement, as I already said. So the main role of the group is to participate in and out of the group. They're going to share examples, offer feedback, support, and challenge one another. So you want them all talking. And as the group develops, the therapists are going to decrease and the members are going to increase their involvement. So you want a lot of back and forth. And the way you do that is to encourage their interaction. For example, if you know that someone in the group, one person's talking about their stuck point and they're doing the challenging questions, you might be looking over at somebody else in the room who's got the same exact stuck point. And you look over at this person, then you look back at the person with the stuck point. Same thing, bridging questions. Well, the next slide will show you that, are ways to bring it to the group level. You want to link members who have similar stuck points. If you have a whiteboard or blackboard, whatever you happen to have, if you can be like in a classroom, that's great. Or a conference room is a great place for group therapy. They've got a place to put their materials and you might have some kind of board you can use. So check in, set the agenda. Does somebody need some time? Keep the check-ins short. So they're not just talking on and on and on, but do you need some specific time today on your stuck points? Did you get your homework done? That kind of stuff. Using the whiteboard. You got to manage personalities and group conflict like every other group therapy. You want to review the out of session practice assignments. They may leave them with you, or the other person takes them and looks at them and puts some marks on them if they need help getting things in the right columns or some suggestions. So bridging questions are things that are going to engage the kind of questions you're going to ask as a therapist that engage the group as a whole. You're going to draw out comments from everybody, identify common stuck points, suggest a common stuck point, and help them acknowledge shared stuck points and shared solutions. Sometimes people come up with wonderful alternative thoughts that they can share with the group and with each other. And you don't want to guilt somebody for not doing their practice assignments. So when other people in the group are doing their practice assignments and they're getting better, pretty soon the person who's not doing them is going to notice that. So you're going to encourage them to bring in their practice assignments, but don't make them feel guilty. Typical rules in the group that you set up in the beginning are things like confidentiality, participation, like we know as therapists, we have confidentiality, but you got to help them understand they shouldn't be talking about what goes on in group outside of group. Participation by both therapists and the group members, we expect it. They may come up with some kind of dropout rule. If you've missed 3 sessions, you're going to have to come back to the next group, or 4 sessions, whatever it happens to be, whatever seems reasonable. Be on time so that it doesn't disrupt the group if you come in late. No telling your trauma stories in detail, being respectful. Now, usually we have them generate the rules. They'll say, turn your cell phones off. The rule usually about interactions outside the group, we're great if you interact outside the group, but invite everyone. We don't want them getting into small little groups so that they're picking on each other, like a group of 2 or a group of 3, what we would call a clique. So everybody or nobody. Now, I don't know if you can do an optional phone list or not. That would be the members of the group call each other to talk about the assignments or anything else they want between sessions. And you start with calling the first person on the list, second, third, fourth. I don't know if that would be possible. That would be part of training. And then the expectation is they're going to complete their assignments. So it ends up being very similar to the individual CPT. You're going to have a pre-treatment segment where you know when people are appropriate for the group, they have PTSD. You might even pick out their index event with them before they join the group. Then you're going to have the education session and ending with the assignment to do the impact statement. Then you're going to do processing the trauma, which is the ABC sheets, the challenging questions, and that moves into then using the challenging beliefs worksheets and the trauma themes. And then the last ones are helping them face the future, which are esteem, intimacy, goal planning, etc. So it's very similar. And then this is the last slide, and I think we've left time for a few questions. Although we usually give a choice of CPT or CPTA for with the accounts to patients, we tend to do CPT more. And I would say the same thing goes. If you know both PE and CPT, or CPT and EMDR, or WET, or one of the other PTSD treatments, describe them and give them a choice. As I said, they're going to engage better if they have chosen which therapy they want to do. If you can do it twice a week, that's really recommended. I know it's often not possible, but we know there's a lower dropout rate and sharper declines in symptoms when you'd have less time between sessions. Also doing it without the accounts has a lower dropout rate than with the accounts. They're most likely to drop out right before. There's 2 times when people tend to drop out. One is right before the therapy starts. You've said, okay, you can come to therapy, and then they don't come. They back out. And the next time is if they're going to give an account. The first time they're going to do an exposure in PE, or the first time they would write their account in CPT. So we know there's a lower dropout rate if we don't have them write the accounts. It gives you more time for Socratic dialogue, asking questions, and really making sure that it's in the form of the question and you're not getting over eager and trying to convince them to change their mind. It works better to do CPT without the accounts if there's alcohol involvement by the patient or other memory loss. Like I was saying, traumatic brain injury works better with the traumatic event. If there's alcohol involvement, it's probably better to do it without the accounts. CPT has been done with serious mental illness. Just because you have serious mental illness does not mean you can't have trauma happen to you, but they tend to do it without exposures. So CPT without that, EMDR has exposures, WET has exposures, PE has exposures. So I would probably do a cognitive therapy. It doesn't have to be CPT. It could be some other form of cognitive therapy, but without the exposures if they are serious mental illness, because you don't want them getting too emotionally activated in the session. Variable length, we also prefer because it has better outcomes, because you can tailor the amount of CPT. You can't do that with groups, but you can do that with individual. More complex cases may need more sessions. Some people finish very quickly and don't need 12 sessions. You could start them in group, and if they still have PTSD at the end, then you could move them into individual, which would be a more efficient way to do it. So they've started in group and finish and then after the group is over with, they give them a few more sessions. Doesn't mean you have to do a whole nother course of therapy. So now we're experimenting with doing CPT very quickly. We have one study of 5 days CPT compared to 6 weeks. It's almost finished. In fact, all the data are collected. They're just doing the data analysis now. So we'll be, I'm not the primary therapist on that, but they'll be publishing the findings probably within this next year. If you want to hear what CPT sounds like, the podcast is called This American Life, 10 Sessions. And we have just a few minutes. Would you have any questions?
Well, there are quite a few questions. One of them is from somebody who learned CPT in Kiev.
Okay.
And it's wondering what to do with the patient at the beginning of the therapy when they're asked to read their story and the patient is attached to his thoughts, and what will be the recommendation for work in CBT on the first stage, because sometimes it may be
We don't
very
ask them to
difficult.
read. We don't ask them to read their story. And see.
Well, I understand. I don't know. It said here the story, but it's probably these sort of
The impact statement?
answers related to why. Yes.
I think you have to give them a rationale before they start treatment. And then you say, we're not going to talk about the details, because sometimes you ask them to write their impact statement and they start writing an account of what happened. We don't need to know exactly what happened and all the details. All we need to know is what you think about why it happened. Okay. And how do you think it's going to affect you? So you make it really clear. In fact, our instructions say it about 4 times. We don't want you to tell us your story, what happened, only what you think about why it happened. So we're looking for stuck points. You could go straight to a stuck point log. What thoughts are you having that keep coming back to you? I like the impact statement a lot because you learn so much. But if you really couldn't get somebody to even write an impact statement, I'd at least say, when you think about it, and you do because you're having flashbacks and nightmares and it pops in your head, what thought comes to mind? What do you think about it? That's where I would start then. If they can't sit down and just write an impact statement about what does it mean to you. Other questions?
Okay, thanks. Another question is, what if the patient has no PTSD diagnosis? Would it be a good idea to use the CPT?
I guess the question is whether they meet full criteria for diagnosis or whether they didn't have a trauma. If they have a trauma and have some symptoms, I would say yes. If they don't have any PTSD symptoms, then I'd say, or no trauma, I'd say maybe look for some other, you could do cognitive therapy for depression if they have depression, or work on their anxiety. I mean, there are other therapies. So meeting full criteria is not required, but this is a therapy for people who've had a traumatic event that they're haunted by.
If we see that her client pattern of thinking is distorted by the event, well, what do we do then?
Well, then you offer them CPT. But you don't tell them their thinking is distorted. You say CPT might be helpful to you. And then you help them see that sometimes there's different kinds of thoughts, and some thoughts can keep you stuck in your PTSD. So we talk about being stuck, not being distorted. The way you're thinking about it maybe has kept you stuck. And this way we can have you look at your thoughts. So it's not that I'm telling you how to think. It's you're going to look at your thoughts, and I'm going to ask you lots of questions about those, and we'll look at whether it makes sense or not to say that, because some people are quite convinced their thoughts are truth. And you don't argue about that. Let's just take a look at it. How do you feel when you say that to yourself? Oh, you feel pretty awful. Let's ask these questions when we get to the challenging questions. Let's put that thought, let's put one of your big thoughts up there in that top part and ask those questions. So you're going to do a lot of, that's why you have to do it in the form of a question. You can't convince somebody to change your mind or that their thinking is distorted, but that's the perfect person to get CPT. But I would recommend you read the manual or do the online training, or sometime maybe we can set up a full 2-day training, or 3-day if you want group also.
Sounds fascinating and very needed, yes, because If we are to summarize, in what way the CPT is so successful, what could we say, Patty?
Yeah, well, if you need to show somebody, you can go into our website and you can download articles that show graphs of being very successful. Go to my 2002 article and you can see a graph on their symptoms just dropping like a stone. And 2012 article where we did the long-term follow-up 5 to 10 years later, and there's no relapse even though they had more traumas. We've had people who've gone back into a war zone after being treated and they said, oh, I handled it totally differently. I didn't react the same way. Because this actually was teaching them. Battered women who get CPT are less likely to be abused down the road. So we have lots of data that it works. But I think you can share that. You can share that with the patients. They can watch, if they can speak English, they could watch the video or listen to the podcast. But I think the summary is that you change thoughts that are haunting you and keeping you stuck, and you're just going in circles with your PTSD, and help break out of that and think differently. Then your emotions change.
Wow, so it sounds really, and we can see this and we can already observe this, that this is really a very quick way of getting to what is bothering people the most.
Yes.
And really doing it in such a way that it's manageable for them, that they are not being overstressed and re-traumatized again, and they are willing to participate and think about it in a slightly different way.
Right, because you're focusing on their thoughts. You're not making them go through, because if you ask them to write an account or do an exposure, they may be talking about really horrendous images, but that may not be where their PTSD is or why the PTSD is continuing. If they're blaming themselves because they think they should have done something different in that moment, and they're haunted by that, remembering those gory details is not going to help them. So I think it does make it it's a gentler therapy. And gets them to the same point. They end up without PTSD for the most part, or at least.
But I understand. Sorry, Patty.
Go ahead.
I understand it's not so much about gentle in the therapy, but really not missing the crucial points. Yes, the most sort of stressful elements of this.
But they have to figure it out for themselves, and that's the mistake that a lot of therapists make, is trying to convince them to change their minds. And they'll just they know something is wrong with their thinking because it keeps coming back at them. They can't put it to rest. If they believed what they said, if it's distorted and they believe it, then they're still going to be, they're not going to have PTSD anymore. But there's something about it. They know that their thinking is wrong. Like the woman with the alcohol, if she looks around and sees other women who drink alcohol and don't get raped, she knows there's something wrong with her thinking, but she's clinging to the idea, if I hadn't gone out and had that drink, I wouldn't have been raped. So the conflict is within them. And we don't want to jump on one side of the conflict and try to convince them, because they'll just harden up on the other side. We have to stand back and let them figure it out for themselves, and then they own it. And that's where the real change comes from, is when they figure it out. It's just like, I can show you 30 studies, or I can show you, actually there's been 86, I just saw something yesterday, there have been 86 studies on CPT of various sorts. I could show you all that. But when you treat somebody and they get better, you go, oh, it really works. You're not going to believe it until you see it. And the same thing with them. They have to try it and learn it, and then they believe it. Okay. Shall we finish on that note?
Tak, myślę, że nie tylko możemy, ale musimy już zakończyć.
Yes, I think we have to
Yes,
finish at this point. We have to take care of ourselves as well, and
absolutely.
sometimes put a stop. So thank you very much, Patty. It was an incredible introduction to the topic of important, efficient work for about what's the most important for those people. You told us about that. If we address it appropriately, if we start working with it, we can change the quality of life of people. It's fascinating that you're telling us that veterans are trained in this method of questioning those their thoughts, are capable of returning to the war zone after this therapy into traumatic events, and they perceive, they handle them in a different way, they can cope in a different way. So this is incredible.
Yes.
So a lot of incredible inspiration. So thank you very much, and we definitely
welcome.
need to meet. We will definitely meet, because a lot of us learn it. We want to go deeper in it. So thank you very much for your time.
In our website, there are a number of articles, this research studies that you can just click on and open up and get to if you want to see any of the studies. Okay. Thank you very much.
Tak, bardzo.
You take care.
Dzięki bardzo, do widzenia, do widzenia, do
Thank
widzenia.
you. Thank you very much.
Bye bye.
Bye.
Bardzo, bardzo ważnym dzisiejszym spotkaniu. Mamy nadzieję, że zainspirowało Was to do tego, żeby się przyjrzeć i zacząć właśnie zdobywać wiedzę i umiejętności w obszarze CPT. Ja chcę tylko powiedzieć, że my nagrań nie wysyłamy do nikogo indywidualnie. Tutaj widzę, że na czacie pojawiły się takie prośby. Drodzy Państwo, tak jak też dawaliśmy znać, no jest to jakiś proces pracy nad platformą, gdzie będziemy to udostępniać, te nagrania, także na pewno to się już odbędzie bardzo niedługo. Jeśli ktoś nie miał możliwości ściągnięcia certyfikatu, bo na przykład odbierał to na telefonie, prosimy, napiszcie do nas, to my Wam podeślemy ten certyfikat. I dzięki wielkie wszystkim tutaj za obecność, za uczenie się, za wzajemne się inspirowanie. Dzięki wielkie naszym wspaniałym tłumaczom. Jak zwykle jesteście rewelacyjni, naprawdę i rewolucyjni. Naprawdę podziwiamy bardzo. Dzięki bardzo tutaj Lideksowi za wsparcie i do zobaczenia, do usłyszenia na kolejnym bardzo ciekawym też spotkaniu poświęconym właśnie terapii krótkiej, kiedy mamy okazję, żeby no, może nawet w ciągu jednej sesji pomóc osobie w potrzebie. Także zapraszamy Was do śledzenia tego. Dzięki, odetchnijcie dziś wieczorem. Do miłego zobaczenia.